A 66-year-old female presents with sudden onset shortness of breath. Now, that's not too unusual for a patient in this age group, but her past medical history makes this case particularly interesting. She has congenital hydrocephalus, which had been treated with a ventriculoatrial VA shunt. Immediately, my mind starts thinking about the potential complications that could arise from having such a shunt, especially given her current symptoms. And so, with that, we dive straight into the imaging. Let's first take a look at the chest X-ray. Initially, it might seem unremarkable. Her lungs appear clear, no pneumothorax, no significant pleural effusion. However, one crucial detail stands out. You can clearly see the ventriculoatrial shunt in situ. Now, you don't place a ventriculoatrial shunt unless you've got a good reason, but this also means there's a direct line from her brain to her heart. And that's where things start to get interesting. Moving on, we get to the real star of the show, the CT pulmonary angiogram, CTPA. This scan gives us a more detailed look at what's going on behind the scenes, and it certainly doesn't disappoint. Right away, something jumps out, a dilated inferior vena cava with contrast reflux into the hepatic veins. Now that's a classic sign of increased right heart pressures, which instantly sets off alarm bells. But that's just the beginning. As we scan further, we spot something even more alarming. A large calcified embolus lodged in the right main pulmonary artery. Not only that, but there's also a smaller, more distal embolus. And as if that weren't enough, we also see calcifications in the right atrium and tricuspid valve area, which is a big clue that the emboli have been there for quite some time. This patient has been walking around with a ticking time bomb in her chest, and today it decided to cause trouble. So, what's going on here? The diagnosis starts to fall into place. Multiple calcified pulmonary emboli that likely originated from the area around the right atrium and tricuspid valve, where the ventriculoatrial shunt is located. These emboli have been silently building up, and now they're causing significant issues, like raised right heart pressure and pulmonary hypertension. Now you're probably thinking, what other conditions could cause calcified emboli like this? The truth is, not much. The presence of these emboli, particularly their calcified nature, really narrows down our differential diagnosis to one culprit, the ventriculoatrial shunt. And why is that? Well, the catheter from the shunt acts as a foreign body. Over time, clots form around it, often in the right atrium or near the tricuspid valve. When those clots break off, they travel to the lungs and lodge themselves in the pulmonary arteries. Once there, they calcify, becoming rock-hard emboli that wreak havoc over time. Let's talk a little bit about ventriculoatrial shunting itself. This procedure revolutionized the treatment of hydrocephalus by creating an alternative pathway for cerebrospinal fluid, CSF, to drain. In this case, the shunt directs CSF from the ventricles of the brain into the right atrium of the heart, where the fluid is absorbed into the bloodstream. It's an ingenious solution, but not without its risks. Over time, the presence of the shunt line in the right atrium can lead to clot formation, and that's where the trouble begins. These calcified clots don't just sit idly by. They cause a buildup of pressure in the pulmonary arteries, leading to secondary pulmonary hypertension, a serious condition with a grim prognosis if not managed appropriately. In fact, the mortality rate for patients who develop pulmonary hypertension due to ventriculoatrial shunts can be as high as 50 to 100%. And if that wasn't enough, there's another potential complication to be aware of: shunt nephritis, an immune-mediated disease caused by chronic infections of the shunt, often from organisms like Staphylococcus epidermidis. This can cause low-grade bacteremia and inflammation, but thankfully, there's no evidence of that in this particular case. So what's the next step for this patient? First things first. We'll need an echocardiogram to assess the right heart function and measure the pressures in the pulmonary arteries. This will give us a better understanding of how severe the pulmonary hypertension is. We'll also need to consult with both the cardiologists and the neurosurgeons to determine the best course of action. Given the calcified nature of the emboli, surgery might not be the immediate option. Instead, a more conservative approach could be the way forward, focusing on managing the raised heart pressures and monitoring the patient closely. This case is a stark reminder of the long-term consequences that ventriculoatrial shunts can have. While they're life-saving for hydrocephalus patients, they come with their own set of risks that can pop up years down the line. As radiologists, we need to stay vigilant and always be on the lookout for these kinds of complications. If you found this case as fascinating as I did, make sure to subscribe to Radiology Made Easy on YouTube for more in-depth case discussions. And hey, if you've had similar cases or thoughts on how you'd approach this, drop a comment below. Let's keep learning together.